Very happy, very grateful that Dr. Wilcox is presenting today. Dr. Wilcox was a school psychologist for 8 years before completing her PsyD in school psychology in 2009. She completed postdoctoral training in clinical neuropsychology, where she practiced as a licensed psychologist until joining the Workland School of Education at the University of Calgary. And Dr. Wilcox is a registered psychologist in Alberta and a nationally certified school psychologist. And I hand it over to you, Dr. Wilcox. Thank you very much.
Great, thanks, Julian. Yeah, so mostly we'll answer questions at the end, but Julian, if you see any questions about clarification or confusion that I need to answer right away, please feel free to jump in and let me know, because I'm not very good at monitoring the chat box.
Okay, I will do. Sure.
Trying to get my slides to move. All right, so last session, this is just a really quick review of what we talked about. We talked about the rationale for CBIT, and the main rationale is that we really can't control the biology, so we need to focus on the things that we can control. So the FBA portion that we talked about is really controlling the antecedents and the consequences to reduce the likelihood of tics. And then today, the habit reversal part is what individuals can do to reduce their chances of tics by modifying their behavior. We also talked about who it's a good fit for. We talked about it's good for older children so that they have enough awareness of their tics and their premonitory urges in order to actually engage in the tasks. And also somebody who is interested in it. So CBIT is a lot of work. So for kids who are like, yeah, my tics don't bother me, CBIT isn't going to be a good fit. So it has to be somebody who really wants to have more control over their tics. We also talked about the evidence about how it works and how it has long-term effects. So even after CBIT ends, the people still have those skills, and so it still helps them to manage their tics. We talked about how to select tics to target, focusing on tics that are most annoying or problematic, but also then looking at tics that are going to be successful for those first ones. We talked about what functional behavior assessments were. So really looking at the antecedents. So what are the things that happen before that are likely to be increasing the tics? And what are the consequences or the things that happen after that are likely to reinforce it? And unlike other behaviors, these are things that students generally aren't aware of. So they're definitely not doing these things to attempt to gain those consequences, but they're still reinforcing on a subconscious level. So then the functional behavior interventions really focus on how can we modify the environment ahead of time or modify the consequences afterwards to try to reduce tic behaviors. So today we're going to briefly review the schedule. So basically the different sessions and what's covered in them. Psychoeducation about tic disorders that you go over with the child and the parents, creating a tic hierarchy, inconvenience reviews, awareness training for both the tics themselves and for premonitory urges, competing response training, self-monitoring, homework, relaxation techniques, progress monitoring, and fidelity. So this is just a basic outline of the different sessions. And if you look closely at it, you'll see that there's actually a lot of overlap. So it's a building. So you continue to do things that you did early, and then you add onto it as you go along. The ones in blue are the ones that we're going to be talking about today. Some of the grayer ones are things we talked about last time, or they're repeats after the first time they show up on the schedule. So during the first session, you really devote a lot of time to psychoeducation. Sometimes families know a lot about this, but lots of times they don't, even after they have a diagnosis of Tourette's or a tic disorder. So it's really important for them to understand, and so for you to invest that time. So the different components of psychoeducation about tic disorders include identifying the types of tic disorders that are in the DSM-5, the types of tics, the phenomenology of tics, causes, natural progression, prevalence, and comorbidities. And so I left comorbidities off today because we did spend a lot of time on it last time. But if we think about the DSM-5 and the different types of tic disorders, you can see that Tourette's disorder requires that an individual has multiple motor tics, one or more vocal tics, and they don't have to be concurrent, so they can occur at different times, that have persisted for more than 1 year and occur sometime before the age of 18. So the persistent or chronic motor or vocal tics is single or multiple vocal or motor tics, but not both, that have persisted for more than 1 year, starting before the age of 18. And then provisional or transient tic disorder is single or multiple vocal tics that have persisted for less than 1 year, but also began before the age of 18. So it's important for families to know that the differences between these are somewhat arbitrary. So they shouldn't really get hung up on which disorder their child has. And CBIT isn't intended to address tics no matter what the disorder. So this is more for information about how clinicians make diagnostic decisions rather than what life is like for individuals with tics. All right, so if we think about the different types of tics, simple motor tics are single motor movements. So for example, eye blinking or head jerking. Complex motor tics involve multiple movements. So arm movements usually involve multiple movements and groups of co-occurring simple motor tics. So for example, if somebody blinks their eyes and jerks their head in a single tic, then that would move from a simple motor tic to complex motor tic. Simple vocal tics include throat clearing and grunting, while complex vocal tics include words or phrases. And I wanted to point out too that coprolalia is uncommon. So in the media or even in any like documentaries that you see around Tourette's, it often is the highlight because it's pretty sensational. And so people focus on that, but really most people with Tourette syndrome do not have coprolalia. So most tics are preceded by premonitory urges. So this is an inner tension similar to that feeling of when you need to sneeze or scratch an itch. While most have premonitory urges, not all do. And younger children or individuals with cognitive delays often have difficulty identifying them. So I have a little activity here for you so that you can get a sense about what these premonitory urges feel like. So I want you to hold your eyes open as wide as you can without blinking. And I'm going to ask you to hold them here for long enough that it's going to feel uncomfortable for you. So you're really going to get this urge that you need to blink. And you have to kind of not do it for a little while here. All right, now you can blink. And you'll notice that after you had kept your eyes open without blinking for a while, you didn't just blink normally after that. You probably blinked lots of times right in a row, trying to get your eyes to feel right. So while this is not really a perfect example of what premonitory urges are like, it does give you kind of a sense of what that physicality of it is like for individuals who have tics. This is an example that Doug Woods gave to us during the official CBIT training. So there are a couple of times I'm going to mention him today because I want to make sure that I give credit to where I got this information from. All right, so the phenomenology of those premonitory urges are some of the triggers include sensory stimuli. So something in the environment can make people start to feel like they need to tic. If they hear specific words or phrases, that can trigger a tic. It can also include urges to do dangerous or forbidden things, which is kind of where coprolalia falls under. The need to get a just right feeling and a need to even things up. So again, that highlights a little bit too about the comorbidity with OCD that we spoke about and the importance of differentiating behaviors to determine whether they're tics or OCD behavior. And if you remember from last time, the way that you clinically do that is to go in about what's going to happen if you don't do this. So if it's a tic, kids are going to say, it just doesn't feel right. I just need to do it. But if it's an OCD behavior, then they're probably going to tell you that something bad could happen if they didn't do this behavior. So during the psychoeducation, you also talk about the biological aspects of Tourette's disorder. So you talk about the fact that it is a genetic disorder. Currently, there's not a specific gene identified, and most likely it's multiple genes that work together to create the Tourette's disorder. There are also neurotransmitters involved, such as glutamate, GABA, serotonin, norepinephrine. And when drug therapy is used, this is what drug therapy targets for individuals with Tourette's disorder. And then neurobiologically, the basal ganglia is part of the brain that's pretty deep within the brain, and it is involved with a lot of motor behavior, and it is involved with Tourette's disorder. So Doug Woods gave this example as well to explain to kids the role of the basal ganglia in Tourette's disorder and tics. So he describes it kind of like a spaghetti strainer. So you know that you take your spaghetti, you dump it in the strainer, and when the strainer is working correctly, all the water goes through and all the spaghetti stays in. So if we think of the spaghetti as tic behaviors, the basal ganglia is kind of inhibiting all of these unnecessary motor and vocal behaviors. But sometimes the spaghetti strainer gets broken, the holes get too big because maybe some kid was playing with it and made the hole too big. And now some spaghetti escapes through that strainer. So those tics are like those pieces of spaghetti that escaped through the strainer where the holes were too big. Also, we talk about the natural progression. So this study found, kind of asked kids when their worst tics ever were. So you can see there's a little spike around age 7, and then there's a more persistent spike around early adolescent, tween kind of age, which is a somewhat cruel reality, because that's when kids tend to be the most sensitive and self-conscious about themselves in the world, and also the most concerned about fitting in with other people. Finally, in the psychoeducational aspect, we talk about the prevalence. So how many people have Tourette's syndrome or other tic disorders? So you can see here about 3 to 8 out of 1,000 are diagnosed with Tourette's. About 4 out of 100 have some kind of tic disorder, and between 12 to 18 out of 100 have some kind of tic in general. So you can see on the right, I added on that one what that would look like out of 25, because a classroom tends to be about 25. So 3 to 6 kids out of 25 have some kind of tics. So teachers are likely to have several kids who have tics in their class every year. So it's not that uncommon, again, for teachers or in the school environment for kids to experience tics. So next we're going to move on to creating this tic hierarchy. So the tic hierarchy really guides the treatment planning. So it helps us to determine which tics we're going to focus on first. So generally we start with the most bothersome, but we do consider the client wishes and likely success. So an adolescent that I worked with, his most painful and annoying tic was one where he tightened up his stomach muscles. So because that one is really hard to see, we decided not to do that one first and to do ones that we could see so that he could be more likely to have some success and understand how it worked, so that he could be more likely to have a good competing response for the tic that was really hard for us to see and get at. The initial list comes from the YG-TSS that you probably did when you diagnosed the Tourette's disorder. So then you go through every tic that's on that list and you give a SUDS rating to it. So subjective unit of distress between 0 and 10. And you keep this list and you review it each session, and you ask the student to give a new rating for it. And then you can use that information for progress monitoring later to see if the SUDS ratings are going down. You also go through and add new tics as necessary, because we know that tics wax and wane. So throughout the progress of the treatment, new tics can arise, and we want to make sure that we add them to the tic hierarchy. So we'll use the tic hierarchy to choose the tic to focus on for both the functional behavior assessment, which we went over last time, and habit reversal training, which we will go over this time. So the inconvenience review, in this again, we ask the child to identify everything that they hate about tics, all of the things that make it bad, right? So sometimes they're painful or uncomfortable. Sometimes it makes it hard for them to do activities that they want to do because it's not safe. Sometimes they have trouble accessing their education because of it, or kids make fun of them. So all of those things would go into this inconvenience review, so that they can remember why they're working on this. So again, this process takes a lot of work and effort. And so paying attention to the things that you hate about tics will help motivate you to engage in the hard work that you need to do throughout the process. All right, so before we get into habit reversal, it's really important first to focus on awareness training. So again, you can't really focus on making a change to something that you don't, that you're not aware of and you don't understand when it's happening. So before you actually begin the training, first you explain the purpose to the kids. So again, it's so that you can be aware of what's happening, because you can't change your behavior until you're aware of it. You work into describing the tic, and then acknowledging the tics, describing tic signals, and acknowledging tic signals. So again, reiterating that you have to know when the tics are happening or are about to happen before you can work on controlling them. Tic description is really hard. So it's important during your sessions that you really spend a lot of time here and support students in this process. So you don't want to go through this quickly, and you don't want to let kids off easily. You want them to really spend a lot of time thinking about the tic and all of the things that are happening during the tic. So during this first part, the client describes the tic. So you have them describe the tic in great detail. You describe what happens in every part of the body. So you start with any sensations preceding the tic, all the way until the tic is completely over. So sometimes during this, talking about the tic will make kids tic a lot more, but not always. So if the patient isn't having the tic during that session, you can encourage them to fake it. And then when you've gone through all of this, again, in very great detail, and the patient can't think of anything else, you can add some suggestions for things that you see that maybe they haven't noticed. And so again, these are suggestions, and you would ask them, do you think this is happening? And they would either say yes or no. So you're not telling them how to describe the tic, but you're just telling them some things that you see to see if it fits with what they feel like and what they're experiencing. So some tips to help you in helping the child do this is, before the session, do the tic yourself and try to describe all the parts of it. One, this will give you some empathy for them and how much work and how hard it is to do it, but also it will help you to identify maybe some things that they could be missing in it. So this would be something that you would do on your own before you are in the session with them. So you would have your notes and your understanding about what that tic is like. It also gives you some empathy, because as I said, sometimes tics are uncomfortable or painful. So if you do one of these tics a couple times, you'll get those sensations again as well, providing some empathy for them. Be aware that sometimes body parts are involved that aren't as noticeable. So during these, it's important not to be behind a desk, because you really want to see the kids from head to toe so that you can notice all aspects of what's going on with their tic. We start off from that focal point and work outward. For vocal tics, patients often describe the sound rather than what they do. So you really want them to focus on what's going on in their throat and in their mouth and with their tongue, and not just focus on the sounds that they're making during the vocal tic. Interestingly, really describing the tic isn't what's important to us. The main goal is to get them to engage their attention and to focus on what happens when they tic. So again, it's that putting awareness to what's going on so that when we go to this habit reversal, they know when it starts so that they can use the habit reversal or the competing response before the tic happens. So there are some common mistakes that clinicians make in this awareness training. One is jumping in too early. Sometimes we want to save the kid and jump in and give them all of the information, but that's not really helpful. We want them to pay attention to their own body. So if we're jumping in and telling them what their tic is like, then they're not doing the work that they need to be prepared to do the next stage. So while it's really hard sometimes, we really need to keep our mouth shut for a while and let them go through this challenging process of describing their tic. And this first one is really the hardest one for kids. After they get this sense about what it's like, it's a little bit easier. It's still hard, and some, depending on how invested they are, still struggle. But this first one especially, it's important to make sure that they understand how to do this and to really pay attention to their body and what's going on with their tic. Another common mistake is stopping the process too early. So the kid will give you a description of the tic, pretty cursory, gives you a general sense of what's going on, but they really don't get into the minute details of what's going on in their body, and we can't let them do that. We need to have them really engaged to understand all aspects of the tic, even the teeny tiny ones that are going on. Last one is related to that one and not getting a thoroughly detailed description. So again, taking that pretty cursory basic description, and we don't want to do that. We really need to take time to understand the tic so that we can effectively create a competing response and implement it. The next part is response detection practice. Now we just need the kid to start noticing when he or she is ticking. So first you would demonstrate it. So you would demonstrate the tic, and then you would demonstrate how you would let the clinician know that you're ticking. If needed during this, patient can simulate tics. So obviously it's better if they are naturally ticking, but if it's a case where they're not doing that, simulated tics can work for it. Then you have patient practice. So the therapist and the patient chat or play a game or do some kind of activity. The patient lifts his or her finger every time they tic, and then the therapist monitors that and gives feedback, and you continue until they get about 4 out of 5 correct. So this isn't one where you necessarily have to tally it, but you want to get a general sense. We want them to be pretty accurate in being able to detect their tics before we move on to the next stage. So during this, again, when the patient tics, if the patient successfully raises the hand to acknowledge the tic, the therapist praises the patient briefly, and then you continue on with whatever task you're doing. Unsuccessful, so the patient tics but doesn't raise a finger to acknowledge, and you notice it, then you prompt the patient. So then you just said, that was a tic, they raised their hand, you move on. So no kind of judgment, just helping them to be able to recognize and understand it. Some common mistakes during tic detection. So creating an unnatural environment. So this is something, especially when you're new to this, that it can be really easy to just stare at them, right? Which is going to make them feel really uncomfortable. You're not going to have a natural conversation or play a game, which makes the whole process less easy for them. So you really want to figure out how you're going to watch them closely without intentionally staring at them and making them feel uncomfortable. The other common mistake is not giving feedback. So especially with therapists who do a lot of talk therapy, where the talk is the therapy, it's really easy to pay too much attention to the conversation. In this one, the conversation is not the therapy, it's the background, and the therapy is going to be that habit reversal. So it's really important that you kind of are only half attending to the conversation so that you can pay attention to the behaviors. Another reason that sometimes people don't give feedback is that they don't want to interrupt. But again, the interruption is quite brief, and that is the purpose of this activity. So you really do need to interrupt. So again, for therapists who do mostly talk therapy, this is a little bit more challenging. So you may want to do some simulated practice before you work on it. Therapists who do assessment or behavioral work that requires listening, monitoring, tracking tend to be a little bit more skilled at this because they have practice of kind of paying attention to what kids are saying while also monitoring their behavioral responses. So then after the clients are really successful in acknowledging and identifying their tics when they're happening, then we want to move on to detecting them before they happen. So in this one, when the patient tics, they raise their hand to acknowledge the premonitory urge, and then you praise them for doing this. If the patient does not raise their hand to acknowledge the premonitory urge, then they're probably going to tic, and then you prompt them. Sometimes they'll tic, and that's when they'll do it. And so you still praise them for noticing that they ticked and encourage them to try to notice before they tick. So during this process, we want to identify the premonitory urge. So identify what that feeling is that says, I'm about to tic. Therapist simulated practice. So again, you can simulate it for them first. Same thing if the patient needs to simulate the tics because they're not ticking during this session, they can do that. So patients practice during this, again, chat or play a game or engage in some kind of activity. Patient lifts finger before he or she tics. Therapist monitors and gives feedback, and then again, you continue to do this until they're successful about 4 out of 5 times. So again, the steps to this are identical to the steps that we did earlier, except that we're hoping now that they can identify their tics prior to when they happen rather than while they're happening. It's really important to note here that sometimes this can make the tics feel worse because they're paying more attention to them. So it's not uncommon during this first session and then that homework in between the first and second session for the clients to actually say, this is making my tics worse. It generally isn't, but because they're paying so much more attention to them, it feels like they're worse. So it's really helpful to be upfront with them about that so that they know what's going on and they have an explanation for it rather than prematurely leaving because they're saying what you're doing isn't helping me. Then we move into competing response training. So in competing response training, we choose a competing response, so something that the client is going to do instead of doing the tic. So the competing response should not relieve the urge. So they should still get that icky premonitory urge feeling during this process, but they need to then allow it to dissipate while they're doing the competing response. The competing response should be at the very beginning of the movement. Again, one of the reasons why this tic description is so important. So we know when it starts so we can target where the competing response will focus. After you come up with the competing response, you teach and demonstrate the competing response, and then you practice the competing response. There are 3 rules to creating a competing response. The tic, you cannot do the tic while doing the competing response, or it makes the tic less noticeable. So our preference is that the tic is impossible during the competing response. Sometimes it's not, and if it's not, we want to at least make the tic less noticeable. The second one is that you can hold it for a minute anywhere or until the urge goes away for 1 minute. So some things to note. So you have to be able to do it in the shower, right? So putting your hands in your pocket is not going to be a good competing response. You need to be able to do it if you're playing a sport. So that one is one of the most challenging ones when you're coming up with competing responses. So one that you really want to have at the forefront of your mind. The third one is that it needs to be less noticeable than the tic. So there are some competing responses that fit the first two, but they're loud or uncomfortable or super noticeable, and we don't want that. We want this to be less noticeable so that people can go about their day without attracting attention that they don't want or experiencing any kind of conflicts that way. So for the tic you're working on, you have the patient come up with the competing response. So you go through the rules to determine if their competing response meets all three. So you repeat this until you come up with a competing response that fits. So it is not uncommon, especially for adolescents and children, to come up with competing responses that don't fit those three rules. So you have to go through them, oftentimes come up with multiple competing responses before you find one that's going to be a fit and that matches the rules. If the patient struggles, and I would say struggles for a while on this, then you can provide some options, but the patient then must buy into it or you don't use it. So it might actually be the best competing response that you've come up with, but they don't like it, so you're not going to use it. Because the reality is that they have to be willing to do this throughout the week when they're not with you. So even if the competing response that they like is probably not the best, we want one that they're actually going to use. And then sometimes that next week, they'll come and say, I don't think that competing response was the best. I think we should change it. And then you can change it. But really having autonomy and ownership of this is important for the patients that you're working with. Some examples of potential competing responses. So for leg movements, a common one is pushing feet into the floor. And if standing, lock your knees so that you can't move your legs. For mouth and facial movements, a common one is slightly clenching jaw, again, slightly, because this shouldn't be uncomfortable, and press lips together. For arm and hand flicking, locking elbows and extending fingers. So one kid that I worked with, he called them blade hands. So putting your hand kind of like this. For head jerking, tucking the chin and slightly tensing the neck muscles. And again, really focusing on slight tensing for all of these because they're not supposed to be uncomfortable. So when you and the patient come up with a competing response, you would demonstrate it, make sure they know what it looks like. And then I would say on this one, you would time it to demonstrate how long a minute is. After this, if you have a good sense about how long a minute is, you don't have to time it. It doesn't have to be an exact minute, but you don't want it to be a 35-second minute, right? Or a minute and a half minute. So make sure that you have a good sense about how long a minute is so that you know if the student is holding it long enough when you're doing your practice. So again, you chat or play a game. The patient uses the competing response when they notice an urge or when they notice that they're doing a tic if they missed the urge. They hold it for at least a minute. Around that time, you ask them if the urge has gone away. If it hasn't, they continue holding it till the urge goes away. So you kind of are paying attention to this game or chat, but mostly paying attention to whether or not they're doing the competing response. And you do this until the patient does it correctly about 4 out of 5 times. So some common mistakes, again, for these competing responses is not focusing on the beginning of the movement. So if you try to do it in the middle, the tic is probably going to win and it's not going to be effective. Another common mistake is the therapist choosing the competing response for the patient. Not giving adequate feedback during practice. And probably One of the more common ones is not requiring them to hold the competing response for at least 1 minute or until the urge goes away, whichever one is longer. All right, so then moving on to homework. So again, most of their time is not going to be with you. It's going to be with their family and at school. So you make a plan for using the competing response in both planned scheduled times and unplanned times. So they try to do it all of the time, but then they have some planned times throughout the week where they really, really just sit and focus on using their competing response. So they do it with each session, you're going to add tics. So on session 5, you're going to do it with that new tic, and they're going to continue with all their previous tics. You're also going to continue the functional interventions, again, with the new tic and all the previous tics, and that one has a lot of parental involvement. So relaxation is not really part of habit reversal, but it is an important supplementary piece. So we know that anxiety increases tics. So we add relaxation to kind of help alleviate some of that anxiety to support the process of the habit reversal. So one of the things that we teach is that diaphragmatic breathing. So learning to breathe from the diaphragm. I'm sure most of you have things that you like for your diaphragmatic breathing. So making sure they're long and slow. Some examples for kids are like blowing out the candles, blowing up a balloon, 4 square breathing. So you breathe in for 4, hold for 4, out for 4, hold for 4. So there are lots of other ones. But so finding 1 or 2 that works for the kid. And again, that will be something that they practice throughout the week after they get to the week where you start working on relaxation techniques. Also then, you'll work on progressive muscle relaxation. So I know that there's some research suggesting that actually you don't need the tensing part, but I think for most kids, in order to understand what relaxed muscles feel like, they need that contrast between tense and relaxed muscles. So typically it involves tensing muscles for 5 to 10 seconds and then relaxing after that. So there's a script that I really like for kids on this. The original one was from an article in the 70s, but it's quite hard to find. But there's a summary of the activities on this link, so it'll be on the slides when we post them later. And it really gives concrete things for kids to kind of understand what's going on. So one is smushing your toes in the mud and then relaxing them. One is pulling your head in like a turtle and then relaxing it. One is pretending that you have a fly in your forehead and you scrunch up your nose and your forehead to try to get the fly off. One is squeezing your stomach in so that you can get between a tight fence. Another one is tightening your stomach because a baby elephant might be stepping on you. You can see clenching your jaws because you have jawbreaker gum that you're trying to chew, and squeezing your hands to squeeze lemons. So again, having those concrete things to hold on to, I found are really helpful for kids in understanding how to engage in progressive muscle relaxation, but you can use whatever progressive muscle relaxation tools you like for this. So it's, again, just teaching them some skills. It's not a really formalized, you have to do these specific activities to teach them progressive muscle relaxation. Self-monitoring. Okay, so again, that awareness is necessary, but not enough. We want them to kind of pay attention to these things, note frequency differences, right? Do we do it all day long or just once or twice a day? Again, paying more attention to the day, time of day that they're more likely to occur, situations that increase them. And after competing response training begins, again, they self-monitor their use of competing response and the effectiveness of it. For the scheduled portions, they schedule about 30 minutes, 3 to 4 times a week to intentionally monitor that tic and use their competing response. It's helpful to try to do this during high tic times, and then they tally each time a tic occurs during those sessions, and a parent or support person should observe or monitor that with them during those intentional times. Progress monitoring. Using those SUDS, so again, during that tic hierarchy that you do at the beginning with the SUDS ratings, you use that to measure improvement and use it as a motivator. So I found that kids will often say that they're not improving, but then we'll go back and look at their SUDS and actually they've gone down significantly. So for any of us, when we're trying to do something new in the moment, we often don't notice those differences. So collecting data is really important to demonstrate that there is change, and then that can be used as a motivator, because if it's feeling like it's not working, it's easy to give up. So again, having data to go back to show this is what you said, right? 3 weeks ago, you rated this as a 9, and today you rated it as a 7. So still it's not comfortable, but it's an improvement from where it was before. And then near the end of the 8 sessions, you work on relapse prevention. So you anticipate and plan for symptom recurrence. So what are the things coming up that are likely to make your tics worse? Going on vacation, starting school again. So it can be different for different kids, but you kind of plan for that. You review the strategies, you make sure that they understand how they work, help them to develop some realistic expectations that there probably will be times when their tics will surge again, and reminding them that they have some tools to control them. You can plan for some booster sessions. So typically when the sessions end, you have a couple weeks so that they can start to do it independently without you and just have those booster sessions. Sometimes, again, Doug Woods had mentioned that kids would come back even a year or two later that something was coming up that they knew was going to be challenging for them, and they just wanted a couple booster sessions to make sure that they were on track for using competing response as well. Also, if you use the workbooks with them, that's helpful because then they have access to that paper copy of information about how they can use this. So if they forget stuff, they can go back and look at their workbook to remember how to engage in their competing responses. And then again, provide referrals as necessary if they need additional treatments beyond what you've provided them with CBIT. And that's it. So at this point, I don't see any questions. If anybody wants to post one in there or speak and ask a question.
Yeah, I would reiterate that as the opportunity to ask a question to Dr. Wilcox. Please do use the chat function there to pose your question. There's a question, Dr. Wilcox.
All right. So there should not be a problem with competing responses causing pain or discomfort. If they do, then that's not a good competing response. So we want them to be able to do this. It's supposed to be easier and better than the tics. Yeah, so again, that's why I had really focused on the tensing should be pretty mild. If it is causing them pain or discomfort, you should probably find a new competing response. Yeah, so around the competing responses for vocal tics, it's not making a different sound. It's about stopping the sound altogether. So you're not really finding, you're hoping for the premonitory urge to dissipate when you do the competing response. The competing response really focuses on the movement at the very beginning of the tic and stopping that rather than the premonitory urge. Antonio, I don't know if there are any specific factors that predict whether the tics decrease in their prevalence in later adolescence. Generally, they do. So I think on the last one, we talked about how about a third of people, the tics completely go away in adulthood, about a third they lessen, and about a third they stay at their same intensity. So for most people, they at least get better, if not go away, but there's a population for whom they don't, and I'm not sure that they know exactly why that happens. Yeah, so for kids, definitely at the first session, parents are there. In all the kids that I've worked with, kids have wanted their parents to be there. So that can be something that's negotiated. If they're not there throughout the session, I would say that it's good to bring them in at the end and have a brief recap so that they know what the competing response is so that they can support their kids with it. But generally, the kids I've worked with have wanted their parents in there. I imagine that for some adolescents, they wouldn't. But again, then it would be good to bring them in at the end, make sure that everybody's on the same page for what's going to be happening throughout the week. Yeah, so the question about whether or not kids should leave class, definitely they should not get out of doing work. So if they do have to leave class, it's really important that they take their work with them. Because when we talked in the FBA about the things that can be reinforcing, getting out of work can be quite reinforcing. So we want to make sure that they don't get out of work. If possible, it is better for them to stay in class so they're not missing instruction. If they need maybe some more quiet in order to engage in their competing response initially, that could be okay, but I would be concerned about them potentially, again, feeling like they always need to leave to do their competing response. So I would be cautious about having them leave. So, but there could be some kids who that's necessary for. Yeah, so a comorbid condition, so ADHD, you would want that to be fairly controlled in order to do CBIT. So you'd want to make sure that they have medicine or whatever they need, that things are okay for them so that the ADHD symptoms aren't interfering with their ability to engage with the tasks that they need to do for CBIT. And Sarah, yes, generally the urges seem to go away in about a minute, but for some people it does take longer. The kids that I've worked with, they generally haven't taken much longer than that. But I have heard stories about for some people they can take a good bit longer, but generally about a minute tends to be enough.